We've seen a couple of different pathways of resistance, some of which I talked about earlier in this session. So one is that when patients respond to, well, there are two ways to think about resistance. You can think about patients who never respond to the drug. They've got primary resistance, so they never respond to Enasidenib or Ivosidenib. And then you can think about patients who do respond and then subsequently relapse. So of the patients who have primary resistance, we think it's all mediated by whatever co-occurring mutations they have, and that those clones end up taking over and not allowing the patient to achieve a clinical relapse. That is most pronounced in patients with mutations in receptor tyrosine kinases like FLT3 and JAK, and in patients with RAS pathway mutations. Those patients are unlikely to respond to Enasidenib or Ivosidenib. Having said that, I try to make the point that being unlikely to respond doesn't mean you're not going to respond. And it's very important for the practicing clinician to think about what else is out there. That is, if you've got a therapy that's better out there, go ahead and give it. But if you're scraping the bottom of the barrel, then there is a response rate with these IDH inhibitors, even with these co-occurring mutations. It's just considerably lower. In terms of secondary resistance, so those are patients who relapse after they've achieved a remission on an IDH inhibitor, that primarily seems to be mediated through the clonal outgrowth of different clones. Again, FLT3, RAS, but something interesting that we've noticed recently is that you can have a patient with an IDH2 mutation who's getting Enasidenib. That patient will then, at the time of relapse, develop a new IDH1 mutation. And the flip is true. Patients with IDH1 mutations develop new IDH2 mutations. So a study really needs to be done that combines these two drugs together for those rare patients. Finally, something I talked about earlier today was that we have now identified resistance mutations that keep Enasidenib and Ivosidenib from binding into their binding pocket. Those were identified in 2 patients we had at Memorial Sloan Kettering Cancer Center. Whether we're going to find more patients like that is going to be an important question, because if this does become a primary mechanism of resistance, then what needs to happen is that the drug companies and the chemists need to develop drugs that are able to get around whatever liabilities these new mutations are creating, similar to what Ponatinib does in patients with CML and the T315I mutation.